cancer screening. Actually, I gave the same talk to WACAP in 2016 when the most recent US Preventative Task Forces guidelines was released. And back then we did not have Zoom, so it was a pain in the neck to present through WeChat, and it's much easier now. So what is the current status epidemiology-wise about colon cancer in the US? The best source of information is from National Cancer Institute, which has a SEER program, and which stands for Surveillance, Epidemiology, and End Result. If you look at the projection for 2020, which is this year, there will be 53,000 people dying from colon cancer this year, and there will be about 150,000 people with new diagnosis of colon cancer this year. If you look at the average 5-year survival, like Dr. Gauss earlier pointed out, the median survival is greater than 50% in 5 years. But if you detect the cancer early in its localized stage, your survival, 5-year survival, can be as high as 90-some%. But if the diagnosis was made when distant metastasis already occurred, then the 5-year survival is less than 15%. To put into perspective what magnitude this problem is compared to other cancers, here is the top 10 cancers ranked by either incidence or by mortality. By incidence, colorectal cancer ranks number 4. If you include breast cancer in the male population, it ranks number 3. But by mortality, colon cancer ranks number 2 after lung cancer. So this is a serious problem. And if you look at the epidemiology over time and see how this is changing, it's quite interesting for the younger age group like Chadwick Boseman. Since the mid-90s, the colon cancer incidence, not mortality, has been going up. And why is that? It's not clear. And yet in an older age group, older than age 50, since the mid-80s, the incidence has been going down. And why is this happening? The obvious interpretation is because age 50 and above is protected by colon cancer screening programs. And it tells you the colon cancer screening has been quite effective. But I wanted to point it out, what's not spoken here is a false sense of safety for people older than 50. Oh, the colon cancer risk is going down. I don't have to worry about as much. But this is not a natural drop of colon cancer incidence. This curve is being pushed down by colon cancer screening. If you participate in colon cancer screening, your incidence will go down. If you did not participate in colon cancer screening program, age 50 itself is not a protection. It's probably going to go up just like the younger age group. How about other risk factors? We talked about age factor. Now let's compare to other races. And luckily, us Asians, the last color bar, Asian in the US has the lowest incidence and mortality rate of colon cancer. The difference is quite substantial as compared to Black, which has the highest incidence, is about 50 cases per year per 100,000 population. The next bar is Native Americans, and the third bar is the blue, which is Caucasian and Hispanic. So we're lucky that we're in the bottom of the ladder in terms of colon cancer incidence and mortality. And there's also gender difference. Male gender has a higher colon cancer incidence as compared to female. How about us first generation Chinese immigrant in the US? The US data may or may not apply to us very well because our diet is different, our genetics is different. Perhaps the data from China is more applicable to us. So let's look at data from China. This was published in the Chinese Journal of Cancer, Chinese Journal of Cancer in 2019. It compared the ranking of colon cancer in 2009, in 1990 to 2017. I left China to come to the US in 1989, so I know exactly what medical facilities were like back then. So back then, we were really a third world country, very backward, and yet colon cancer mortality ranked number 21. As the healthcare facilities improved dramatically over the past 27 years, yet colon cancer mortality went up, ranked number 11. So the incidence clearly is going up, just like that of the US younger population. And if you look at some more detailed data, which is also from China, which was published in the Digestive Disease and Sciences in 2017, the colon cancer incidence has been slowly rising between 2003 and 2009 in China, both in male and female population. And then between 2009 and 2020, the projection is much more rapid rise. So maybe this is a more westernized diet, higher protein diet, among many other unknown factors that we don't know about. So this may apply more to us first generation Chinese immigrant in the US. We have a more westernized diet, and our risk of colon cancer might be rising more rapidly than we realize. How about other risk factors? Well, the most important risk factor we ask in our clinical practice is family history of colon cancer and family history of precancerous adenomatous polyps. If you have a first-degree family member with colon cancer, the risk of your colon cancer per lifetime is increased by 2.2-fold. If you have multiple first-degree relatives, it's increased by 4-fold. The baseline risk we used to quote lifetime risk for an average American is about 6% per year. Now we're quoting a new number of 4.4% because the numbers has been decreasing in the past decade or so. And what about adenoma? Why do we treat family history of polyps as if they have family history of colon cancer? Because the risk of your colon cancer will go up by 2-fold, very similar to family history of colon cancer. And we made a point in our review of systems, everyone should write pertinent negatives. If somebody has no family history of colon cancer, we write in our GI note, negative family history of colon cancer. So we know we asked that question. It was not simply missed. Okay, let's move on to the colon cancer screening guidelines. It's simple, but complicated because of a lot of details. And also there are 3 competing colon cancer screening guidelines right now. I'm going to go through them one by one. The most recent one released by a reputable organization is called the U.S. Preventative Services Task Force. This is probably the most influential organization making cancer screening recommendations. And also please note, this applies to average risk population, not someone who has high risk, meaning family history of polyps, family history of colon cancer, inflammatory bowel disease, or other risk factors, just an average person. The recommendation says between age 50 and 75, everyone should get colon cancer screening. And then between age 76 and 85, everyone should talk with their doctor about colon cancer screening and make individualized decisions. Why is that age group important? I get questions from patients and referring physicians more about that age group than any other age group, because you think you're old, you don't need to do screening anymore. But to the contrary of that belief, the older you are, the less likely you will need colon cancer screening. This is an age-specific colon cancer incidence by age group published by the American Cancer Society this year. If you look at from age 50, if you use age 50 as baseline, it's 1.0. By the time you're age 60, your colon cancer risk is increased by 1.5-fold. By the time you reach 70, your colon cancer risk is increased by 2.6-fold. By the time you reach age 80, your risk is increased by fourfold as compared to the age 50 person. So clearly, age is a huge risk factor. As much as when you reach 80, it's almost like you have multiple family members who had colon cancer. That's a fourfold increase. So if you are going to live up to 95 years old, you're very functional, very healthy, perhaps you do want to consider continuation of colon cancer screening for this particular reason. Now, the second colon cancer screening guideline was released by a group called the U.S. Multi-Society Task Force. There are actually not really that many society in this group. These are the three GI groups: American College of Gastroenterology, American Gastroenterology Association, and American Society for Gastrointestinal Endoscopy. So these three groups got together and made more specific, perhaps more practical recommendations. This recommendation differs from that of the U.S. Preventative Task Force in two major areas. One is it does a tier system recommendation. So tier 1 is colonoscopy or fecal fit test. Within tier 1, it offers sequential recommendation. You offer colonoscopy first, and if the patient does not take colonoscopy, then you do the fecal fit test. Tier 2 will be CT and DNA test and sigmoidoscopy. Tier 3, which is not used in practice at all, is capsule colonoscopy. And capsule endoscopy is good for small bowel, but not really good for colonoscopy. That's why it's tier 5. And Seattle has a biotech company that developed a test called Septin. And here specifically, the recommendation is made against using that for colon cancer screening. So this is one aspect that's different from the U.S. Preventative Task Force in that it offers tier system. And the second area that's different is instead of age 50 across the board, it specifically says Black population should have colon cancer screening started at age 45. The Chadwick Boseman example is a prime example. He would have been missed by all these guidelines anyway. And also based on the earlier data we reviewed, Black population has the highest incidence of colon cancer. So this is a very reasonable modification. And then 1 year later, so 2016, 2017, and now 2018 is another set of guidelines published by American Cancer Society. It's pretty much the same between age 76 and 85, individualized decision, and between age 50 and 75, standard recommendation. But for age 45, American Cancer Society recommends start colon cancer screening across the board, regardless of race or risk factors. So, so we have three competing guidelines from different organizations, depending on how you pick and choose by the patient, by the physician, or by the insurance company. The way I'm handling it now is not all insurance will cover colon cancer screening colonoscopy at age 45, but some of them do, and you just never know. I tell the patient, go ahead and call your insurance. If they cover that, we'll go ahead and do a colonoscopy. If not, at least I offer them a fecal fit test, which is cheap. I tell them this is going to save lives, and even if insurance doesn't cover it, it's not going to put you in bankruptcy. A fecal fit test should be very cheap. So, what is the impact of starting colon cancer screening 5 years earlier at age 45, based on American Cancer Society recommendations? So I did a little bit of a calculation projection just for our Puget Sound area. So our Puget Sound area will have a population of 4.2 million based on census of 2010. I looked up the population pyramid and I found the percentage of population in that age bracket of 45 and 49 is 8% of the population in our Puget Sound area. That would be 336,000. If you calculate the age-specific incidence, 33 cases of new colon cancer per 100,000 population per year, multiplied by 336,000, we will catch or we will have about 110 young colon cancer in our Puget Sound area. This is devastating. 110 is a lot, just for one region. These are bread earners. They're supporting their family at that age group. So this is the people we really want to save, and early detection of colon cancer would be very critical to them. So I would say the same thing. If their insurance covers colonoscopy, do a colonoscopy for them. If not, do a fecal fit test on an annual basis for this age group. Now, that's the current status of guidelines. Let's review some historical landmark studies that supported the notion of colon cancer screening saves lives and prevents cancer. This study was published in 2013 in the New England Journal of Medicine. Around that time, many studies were published in the New England Journal of Medicine regarding colon cancer outcomes. It was incredible. So this study is on the topic of fecal occult blood test. And this came from Minnesota. It's the Minnesota Colon Cancer Control Study from the VA group. At the Minnesota VA hospital, there was a gastroenterologist by the name of Dr. John Bond, and he's been writing guidelines for many years. So he was the head of this study. Excuse me. It involved almost 50,000 participants. It was followed for 30 years. And amazingly, just by doing an annual fecal occult blood test, the colon cancer risk was reduced from 1.0 to 0.68. That's 32% mortality reduction over 30 years by doing a simple fecal blood test. Even if you do it once every 2 years, you will still reduce the colon cancer risk, colon cancer mortality by 22%. It was amazing data. And what about flexible sigmoidoscopy? In the old days, before 2002, the mainstream of endoscopy was sigmoidoscopy. And back then, this again was published in the New England Journal of Medicine about 2012. Back then, you could do randomized studies. Right now, you know, sigmoidoscopy or colonoscopy saves lives. You really can't do randomized studies anymore by for any ethical standard. So this shows it reduces mortality rate over a 13-year period by 26%, and also reduces incidence by 21%. As you noticed earlier, the fecal occult blood test did not show any incidence reduction, because by the time you have a fecal occult test, it's positive, it's already cancer. So you really is focusing on early detection, not on prevention. But for sigmoidoscopy, if we find precancerous polyps, you refer the patient for colonoscopy, you will remove the polyps, and you'll be able to reduce the colon cancer risk. So that's why there's a protection of prevention, reduction in incidence by sigmoidoscopy. And a year later, again, in the New England Journal of Medicine, another study was published, very large size, from the US Nurses Health Study, which involves 121,000 female nurses. And there's a health professionals follow-up study, which involves 51,000 male health professionals. They were followed for many years. So the first slide here shows reduction of incidence. If none of the patients or population used any endoscopy, their risk of cancer will be labeled as 1.0 baseline. If they have polyps, precancerous polyps removed, which will prevent cancer from happening, that will reduce the colon cancer incidence by 40 to 43%. Very powerful data and very convincing data. If you had a negative sigmoidoscopy or negative colonoscopy, your risk of colon cancer in the follow-up period will also be 40 to 56% lower. The colonoscopy has a higher level of predictive value. I did not label this as risk reduction. When you have a negative colonoscopy, there was no intervention performed. The colonoscopy really did not reduce your colon cancer risk, but it stratified your risk, put you in a lower risk category. And after the stratification, you will be able to focus on the higher risk population, the people who have polyps, and you put them into a surveillance program. You will systematically remove any new growth of polyps, and you will be able to reduce colon cancer incidence. Obviously, as you can tell from here, the protection is not 100%. So there will still be people who will develop colon cancer. If you want to prevent it 100%, you can probably do a colonoscopy every day, every month, or every year. You'll be able to guarantee you'll prevent colon cancer, but that would be too excessive in terms of medical procedure associated risks and medical procedure associated expenses. So based on the current interval recommendation, you can reduce the colon cancer risk by 40%. That's pretty amazing. And let's look at the mortality from the same study from the US nurse health study and health professional study. If you have done screening sigmoidoscopy or screening colonoscopy for early detection of colon cancer and prevention of colon cancer, you will be able to reduce mortality by 40 to 68%. Here, the colonoscopy has a higher power of protection as compared to sigmoidoscopy. And that's one of the reasons Congress approved the Colon Cancer Act, Prevention Act, and approved colonoscopy universal coverage for the indicated age group. There was another landmark study which was published earlier in 2000. This really made a huge difference because in the US, all the health policies is data-driven. You gotta have data for something to change. This came from the VA system. We talked about John Bond, who was from the VA system of Minnesota, and David Lieberman is in the VA system in Portland, in Oregon. They published this landmark study in July of 2000 that compared the findings of sigmoidoscopy to colonoscopy. So each patient got a sigmoidoscopy and a colonoscopy. What they figured out, not surprisingly, is that sigmoidoscopy will miss 52% of important proximal colon lesions, advanced neoplasm or cancer. And any logical projection will come with the same conclusion, but only with data. The policymakers were able to change the practice. So that was the guidelines, and that was the historical data. And what's going on now are the colon cancer screening programs really saving lives. And perhaps the most astonishing data came from the Kaiser system from Northern California. And their baseline colon cancer screening rate is about 40% before 2006. And after 2006, they started promoting it, really pushing the envelope. And they're sending out flyers to homes, and they were able to push this screening percentage to over 80%. And during this process, looking at the right axis, their population's colon cancer mortality dropped from 30 per 100,000 population to 15 per 100,000 population per year. That's a 50% drop of mortality over a period of 14 years, and particularly after pushing the colon cancer screening rate to as high as 80%. This is probably the best screening percentage in the country, and I'm really amazed by how much the Kaiser system has been able to accomplish. I don't work for Kaiser, so I'm not biased to say anything good about them. I really admire their accomplishment. And if you look at the specific data of incidence versus mortality, the two curves are different. Once they started pushing in 2006 more screening, the incidence went up first. Why? Because they're finding a lot of colon cancer early on. Those patients would have not been diagnosed if you were waiting for their symptom to show up. So those new colon cancer diagnosis, more colon cancer diagnosis were really early diagnosis. And when you correspond to the mortality and you don't see that mortality increase, you actually see a drop. So the data clearly shows early detection translates into reduction in colon cancer mortality. And if you look at some more details about how Kaiser in Northern California was able to accomplish 80% colon cancer screening rate, their secret is that they did more fecal fit tests than colonoscopy. This is very, very interesting because across the nation, 80 to 90% of colon cancer screening is done by colonoscopy, and fecal fit test is less than 10%. So the Kaiser system is very unique. They have more fecal fit tests as compared to colonoscopy. As we know, the fecal fit test basically does early detection and does not do as much of colon cancer prevention. And so if they have the same data as the national average, I would imagine their accomplishment will even, their success will be even greater. And so these are the Wisconsin group fecal fit test. In the old days, 2005 was 19% of patients, and down to 2010, the percentage of fecal occult blood tests went down to 4%. The vast majority of them were done by colonoscopy, just in comparison to the Kaiser data. And here's the US national data published in 2018. The fecal-based testing, including DNA and fecal occult blood tests, actually has been going down year after year, as way below 10%. And mostly is by endoscopy, colonoscopy primarily. To summarize what we talked about today, there are 5 different ways for colon cancer screening. Colonoscopy is considered the gold standard. It's recommended once every 10 years for average risk population. If you were to do a sigmoidoscopy, it's once every 5 years. This was the standard for many years in the past, but who's going to do a sigmoidoscopy now? If the patient is willing to do a sigmoidoscopy, they're almost always willing to do a colonoscopy under sedation. And CT colonography is once every 5 years. For a while, there was talk about, oh, maybe CT colonography is just going to take over, and who wants a invasive colonoscopy? And why did CT colonography not take off? The reason is many. One is patients don't hate about colonoscopy. They hate about the bowel prep. When you do a CT colonography, you still have to go through the bowel prep. So that doesn't do much. And then there's radiation exposure every 5-10 years. That's a lot of radiation, CT radiation. And the insurance companies don't like that, because when you do a CT, you're going to come up with a lot of incidental findings. You find a cyst here, you find a nodule there. You end up doing a whole bunch of other tests and costs a whole lot more money. So insurance don't prove that as much. That's why the CT colonography did not take off. And then the fecal occult blood test in the old days was guaiac test. It's not human blood specific, so a lot of false positives. And now it's fecal fit test, which is immunoassay and more specific for human blood. And I wanted to comment a little bit more about the fecal occult blood test. And this applies to us Chinese and Asian population even more. If you find occult blood in a stool, it's not necessarily coming from the colon. It can be from anywhere from your mouth to anus. If you have stomach ulcers, that's going to be positive. If you got stomach cancer, it's going to be positive. So usually when a patient comes to me with hemoccult positive test, I always do a CBC. If they are anemic, I would do not only a colonoscopy, I would do an endoscopy to make sure they don't have stomach cancer and they don't have stomach ulcers in the stomach. So very, very important. Just don't simply look at the positive fecal test and say, we'll do a colonoscopy. If you don't find anything on colonoscopy, you're fine. But if you do a CBC, your MCV is low, you've got microcytic changes, or you got anemia, it's important to consider upper GI tract pathology. And then the last test is the fecal DNA test, which has the advantage of not doing any bowel prep, nothing invasive. The FDA has proved this assay. It's done every 3 years, and there's no mortality reduction data yet, unlike the fecal fit test. It's not favored by gastroenterologists nationwide. It's problematic. It's far more expensive. It costs somewhere between $300 to $500 to do that test, the DNA test, and also has a lot of false positives. It's positive, you go in there, you don't find anything, and there are studies showing, well, where do I stop? It's a DNA test. Could this person have esophageal cancer, gastric cancer, liver cancer, pancreatic cancer, anything that would drain fluid into the colon might get detected, and you'll end up chasing a lot of things unnecessarily and without much of a meaningful findings. So most gastroenterologists will probably favor the fecal fit test than the DNA test, but everyone's different. It's one of the options. And my last slide is to compare the 5 different colon cancer screening modalities and see their difference. They all serve the purpose of early colon cancer detection, of course, to a different degree. And they all reduce colon cancer mortality rate, but not all of them prevent colon cancer. Colonoscopy is the one that will find precancerous polyps and remove them, and therefore you will reduce the incidence or prevent colon cancer. Sigmoidoscopy gives you partial protection because you find and remove polyps too. The other modalities, we don't have any data. The expectation is they probably don't prevent colon cancer much, if at all. Well, thank you. That was my time slot.